we have a cancer storytelling event with the Health Library. So that's a Saturday. They'll show a short documentary that a friend of mine made about me writing letters to my kids after my diagnosis. We'll have Brian Fees, who's the graphic artist who wrote Mom's Cancer. So it's a graphic novel about his experience with his mother having cancer, and it turns out his mother was treated at Stanford, I found out later. So he'll be there, give a little workshop, and then we'll have Lauren Toomer, who teaches art and anatomy. She will teach about how to draw the skeleton, and then we will have, we'll have Frisch Brandt talking about letters, and then we'll have my son, I forced him to teach a session on how to use ChatGPT to make a cancer-fighting video game. So that'll be sort of a parallel session there. And then we'll have cancer storytelling from about 3:15 to 4:15 from a few patients we've asked to tell their own story. So please come. We created this event because of the class, so we hope that a lot of the students would be able to attend the event as well. So there's a registration page I think we can send out later.
Yes.
Yeah. And then there's the code today. Any other kind of business before we get started?
No, just make sure that you continue filling out those the attendance kind of assignments on Canvas, as well as the assignments that are there too.
Right. So great to have a session today on caregiving. This is an area that is so important to every patient's life. Anybody who's been diagnosed with serious illness, such as cancer, having a support system around you is really crucial. Again, to kind of playing off last week's theme of kind of, what characteristics did I have that have really benefited me in my care? I have a great support system, a great family. My wife, Christine, there in the back, she's going to be speaking a little later. Without her, I would not be in such good shape that I am today. But not only my wife, but, my brother flew in, he's flown in. He's going to fly in a third time to help us out and drive the kids around, and my 17-year-old has still got his learner's permit, so he goes and drives with him and picks up food from Costco. And my sister, who's in the area in San Carlos, she is an internist, so she can give her medical support as well as support of bringing us food and taking us out to eat, and that emotional support we all need. So I've been a great beneficiary of having a great support system, and I can't emphasize how important it is to have that support system. And so today we have Professor Ronak Trivedi, who's one of my colleagues and good friends from CARE, who's basically the expert at Stanford on research in caregiving. So we'll have Dr. Trivedi speak, and then my wife Christine will speak briefly, and then we also have one of our auditors, Skip Victor, who's a former DCI fellow, who's going to talk about his experience as a caregiver for his daughter at the end. So please join me in welcoming Dr. Trivedi.
Thank you. Thank you, Bonnie. Is this on now?
Yes.
Scoot over here.
Do you, I can advance the slides, right?
Yeah.
Okay.
I'll scoot over here.
Yeah, okay. Cool. So hi everybody. Can you hear me? Is this on? Okay. I'm Ronak, and I'm really honored to be here to play a small part in this incredibly brave and courageous thing that Bryant is doing, and to share some of the work we've been doing with you, as well as sort of hopefully open your eyes a little bit to how we have real gaps in this area, especially as we interface with the healthcare system. Some of you, how many of you are undergraduates? As people were walking in, I was talking. Any medical students? Okay. PhD, other graduate students. Okay, so mainly undergrads and then medical students. So you are all the people who can help us change how we view and engage caregivers. So I'm going to focus in a very short time and talking super fast, kind of steps how we're developing a culture to an intervention, but that's really just a sort of a springboard to talk a little bit more of the broader field as well. I don't have any financial conflicts of interest. I don't know how many of you have been following this. This is something, the Comet Chichinchan. Anybody? Yes.
It's awesome. We went to by the bay, and it's awesome.
This is from Crestview. We're close to where your sister
perfect.
lives.
Yeah.
Right?
Actually, we actually went the first day, but we missed it.
Yeah. So
it was a little too late. Yeah.
So, this comet was last seen last witnessed by Neanderthals from Earth. So it's been, 80,000, 88,000 years ago? And it makes you realize we're just blips in existence, right? We're just mere blips. And anything we can do to leave this planet with this little blip of our life a better place, I think we should do. And I just want to applaud Bryant for taking this opportunity to vulnerably and intimately sharing his journey and making the most of, hit the blip that we have here. So it's just something that's making me reflect a lot about the passage of time and what our very small existence can mean in the grand scheme of the universe. A little bit more practically, what do you think, and I know some of you got a sneak preview, but you can shout out the answer. What do you think is the annual cost of unpaid or family caregiving in the United States? So I was going through the slides and some people were here. So I'm going to let those people hold their answer. I just want people to guess. And this is there's an annual cost. Anyway, just throw out numbers. It doesn't matter. You're not getting graded. So what? So what?
Per person.
How much is it per person? $150,000 per person. Okay, unpaid caregiving. So this is the annual cost nationally. Sorry, I should make that. Like to the United States. $1 trillion. Okay. Going once? Going twice? Anybody? Sorry?
3 billion?
3 billion. So we got a range here. 3 billion to any other. Come on, just numbers. Numbers. Okay, some people who had a sneak preview. What was the number? $600 billion of unpaid care. And this is caregiving to adults. We're not talking of parenting. We're actually not even talking of providing care to children who may have a health condition or disability. Okay, this is the cost of adults caring for other adults. Now that's a lot of zeros. I can't wrap my head around that. So this is today's market cap of these companies right now. So right now, if you think about it, if caregiving was a company, it would be in the top 100, Fortune 100. You have United Healthcare, which is less than that, Visa, which is less than that, and I just needed an OMG emoji to keep it very professional here. That's a lot of unpaid care that we rely on adults to give other adults. What do we mean by caregivers? These are family members and friends who support people who have a chronic condition or a serious health condition. And there's a lot of terms we've used. And 1 in 5 people in the United States are caregivers, so 53 million, which is where that number comes from, the cost comes from. This is a pretty gendered role. So 2/3 of caregivers are women, and caveat, these surveys are always use gender and binary. So 1/3 of all caregivers are not women or men. These questions are always answered in binary way, unfortunately. Mostly these are family members. I mean, Brian just talked about his brother and sister and other people who are stepping in. And these caregiving practices are deeply embedded in culture, whether it's gender roles, like why people provide care. It's all embedded in the culture. There's a lot of joy caregiving brings to people. So 83% thankfully say that actually caregiving does give them joy. And the joy can come from just being useful, right? Supporting somebody you care about, to sort of show the next generation what do you need to do to provide care, what does it look like, to share transmission of values, to feel like you're just bonding. People feel a great sense of kind of bonding with somebody because they're now in this very intimate way supporting them. But it's not without its negative effects. And in the caregiving literature, you're going to see way more talked about the negative effects than the positive, because that's where we need to fix things, right? Common things are caregiver burden, which is specifically the stress people experience as they are providing care. There's a financial cost to it, $150,000 potentially a year. And there's a lot of stress, burnout, anxiety. It all adds up to negative effects. And so that we need to create programs to fix these issues, even while making sure that the positive aspects don't go away or get amplified. In cancer, this has received significant attention. There's been a lot of research over the decades on how do we improve caregiving, our caregiver well-being and quality of life when somebody's providing care for cancer. These are pretty dated data at this point. They're, as you can see, it's 2015. But anywhere between 3 to 6 million people in the United States are providing care to somebody with cancer, an adult with cancer. People are providing up to 33 hours a week, so that's almost a full-time job, if you think about it, right? 33 hours, that's a full-time is 40 hours a week. And actually, a third do provide more than 41 hours of care a week, which is a huge amount of care. And people do all kinds of different things, and I'll talk about that in a minute. And yet, despite this, that this is so common and there's so many needs, turns out that less than a third of our actually have had providers ask them how they are doing and if the providers can do something to help. Come on in, please. Yeah. And I just put an asterisk to say, I'm on the Cancer Collaborative and Research Advisory Board for National Alliance of Caregiving, which is the top policy organization in the US. And they're the ones who every 5 years do these reports. So we are actually working on updating this cancer record. So hopefully soon we'll have more contemporary statistics, because cancer prevalence and all has changed, but cancer caregiving and cancer survivorship has changed a lot too in the last 10 years. More and more people are talking of self-management in cancer in a way that we've talked historically in other chronic conditions like diabetes and heart disease, but it has been much more a recent phenomena in cancer as more and more people are thinking of the chronic care model. So what does we mean by self-management? Self-management is literally everything that the healthcare team tells the patient to do when they leave the clinic, right? Say, make sure you get your vaccinations, make sure you follow his diet, go and get your 10,000 steps, whatever it might be, right? These are the medicines, make sure you take them, whatever, all of that is considered self-management. And caregivers play a huge role. So in the broader chronic illness literature, what we know is that when people have somebody to provide them support, whether it's a family caregiver, just a support structure, they're better at adhering to self-management recommendations, right? And so family caregivers are really important in making sure that things outside of the clinic are taken care of. In serious illnesses like cancer, you also have you might have wound care, you might have other biologics that need to be given, because so much of cancer care is more and more moving to outpatient care rather than inpatient care, at least in the US. So family caregivers are on the hook for all of that stuff. And yet we do not empower caregivers to navigate. And we're going to hear about people who have the embodied knowledge of being cancer caregivers, and they'll be able to speak to this also. But caregivers are kind of still left at a distance. They're still not engaged explicitly and systematically by the healthcare system, and it's something that you all are going to change. Why are we not empowering caregivers? Well, there's multiple challenges to this. There's the individual level, so caregivers themselves don't have the time, right? They just spend 33 hours taking care of somebody. They don't, not to mention they might have jobs and other caregiving responsibilities, and kids and older folks and all kinds of other things going on. They don't have time to come in and be engaged with the healthcare system. There's interpersonal issues, so not everybody gets along, and so there might be some interpersonal barriers to engaging caregivers. Either the caregiver and the healthcare system are not interacting effectively, or within the patient-caregiver dyad, there's some tension, and so it's playing out. There's policy issues. Right now, we don't have, in the fee-for-service model, really good policies that support reimbursement of engaging caregivers. There are reimbursement codes, we're not really using them really well. And then clinic time is, those of you who are going to be physicians, are physicians, already know that there's no time, right? You barely have time to get through the key thing with your patient. You don't have time. You're not being given time to actually be thoughtfully engaging caregivers. And then there's cultural issues, and this is where I'm going to talk a little bit more about. So there's cultural, like language barrier being the most obvious thing that you might come to mind. But there's cultural practices, like who's in charge. The typical way that we think about in the US is like if you have a patient, the partner is the default family caregivers, but that may not be true in different cultures. It may be another woman, especially if the patient is a woman. So those things need to be understood so that we can provide culturally attuned care to our patients. There's gender role differences. So there's a lot of cultures in which, in basically all cultures, women are the de facto caregiver. But to give you an example, there's in the US, about 2/3 of caregivers are women. In India, 81% are women. And what they provide care also is different, and who provides care. So in India, it's more the daughters-in-law, the wives and daughters-in-law. In the US, it's more daughters and the wives, partners. The motivation is culturally embedded, so there might be more a sense of duty in some cultures versus affection or love that might be driving the caregiving responsibilities. Intergenerational care is also culturally embedded. If you think of the cultures that you live in, like who's providing care? If you just think about right now, who's providing care to somebody older in your family, somebody sick in your family, or friends even, and you'll sort of see how this is playing out in your milieu. Among LGBTQ plus groups, for example, there's a lot more peer care than intergenerational care because they often are estranged from their families of origin and often then do not have kids. And so there's a lot more peer support that happens among the LGBTQ plus communities. And then different cultures have a different take, whether it's individualist culture versus collectivist cultures, that matters too. There's certain conditions that are stigmatized, like cancer is one, or dementia. Some of this can be stigmatized, that can add an additional burden. And then there's times that their religious beliefs can contradict with evidence-based approaches. We have a project going on, a paper that's almost ready to get submitted, focusing on this exact issue, actually. I kind of just went through this in the interest of time. I mean, you're going to get these slides, so I put a little bit more on the slides than I'm going to go through, so you have it. But these are all data from the US, and I've kind of touched on it. I'm going to just point this particular statistic out because I'm going to talk about our work, is Asian caregivers in general, of all the racial ethnic minority groups in these national surveys, Asian caregivers are the ones that are most likely to say they didn't feel they had a choice. They had to do it. Like it was their duty. It was expected of them, sorry. They had to do it. So this has led us to come up with this suite of projects that we're calling SUFFERED, with South Asian Family Approaches to Diseases. SUFFERED in my mother tongue is Gujarati, and it means succeed in Gujarati. So our goal is to get people to succeed in and get supported and succeed at whatever conditions they're managing. And we've had historically a suite of studies that are based on Succeed and Web Succeed, so we're able to kind of stay in that. These are the things that gives us jollies as professors. What can I tell you? For South Asian breast cancers, there's our work. My current work is focused on this. 1 in 5 people globally have a South Asian heritage. So a lot of the statistics are coming out of the CARE studies, actually, that Bryant and Lata are co-leading the center. And actually, India just became the most populous country in the world, right? They were surpassing China just not that long ago. I mentioned the cultural context. The breast cancer management is affected by culture. In one study, people said that almost half the people said that sexual taboos were interfering with getting good preventive care like mammography. And in fact, only 3% of people were getting preventive care, preventive screening, breast cancer screening in India. There's a stigma around cancer. In fact, there are actually no words in a lot of the, I speak 2 other languages that are for cancer or survivor. Cancer is just cancer, so it's almost like people, it's just we're not even going to come up with a word for that. And for survivor, American Cancer Society actually has Hindi language materials, which is good, but it's like super high caliber, it's just like the health literacy is very high. And the phrase they use basically, any Hindi speakers here? Any Hindi speakers? Oh, anyway. It translates to those who have escaped cancer. So you can see that instead of like a survivor, which kind of has this positive connotation, like you've survived, like this is good, there's this, phew, you escaped cancer, right? So it's that sort of that stigma and that fear is kind of embedded in the language as well. And our healthcare system, we know this, is not designed to handle this cultural context. We just throw our English materials at people, maybe get a medical interpreter, and fingers crossed, hope for the best. Right? And we know that's not how it works out. I know there's people who are going to be talking about their experience, so these are my parents. My mom has had metastatic cancer for about 19 years at this point, and actually she's in hospice now. So we're kind of looking at sort of the next stage of it, but we've been, as a family, caregiving for a long time. And my dad, who's now 82, this is just 2 years ago, this is Tahoe, they were visiting. And my dad has had long-standing issues with, basic cardiovascular disease, South Asian heritage, it kind of comes with the territory. And the 2 of them I've seen over the years just take care of each other. And that's been a big driver of the work that I've done in terms of making sure that we honor not just the patient, not just the caregiver, but both together, because what they bring together with each other transcends what each one brings in to this. If we just do patient-focused work, then we're certainly missing the caregiver, but if we just do caregiver-focused work, we're actually missing the role the patient and their relationship plays. So this inspired me to come up with this dyadic health behavior change model that this is the most recent version I published almost 10 years ago now. And the idea is, that, so our unique contribution is that this box over here is really focusing on how do the dyadic coping, dyadic relationships, the interpersonal factors, how does that play into how well people can take care of all kinds of different chronic conditions. So this is what we're doing right now. So in the SUFFER study, we already finished this phase. We're kind of finishing up the manuscripts for this. What we did was we talked with 13 breast cancer survivors, 13 caregivers of breast cancer survivors in the Bay Area who are South Asian. And we also talked with 12 clinical providers. This is in the pandemic time, so it's kind of all roughly became Stanford, even because there was no way to do community outreach at the time. There was no community centers. And we did interviews and surveys with them to kind of ask, because we just don't know. This is a very, very uncharted territory of South Asians experiencing breast cancer. What is it like to even do that? So we did these hour-long interviews that we thought might be too long, or we were told too long. And actually people spent 2 hours with interviews with us because they really had stories to share, and then nobody had asked them these stories, right? So we are now analyzing these and trying to get them out. And basically we use that to also identify what do people need in home and community-based services, what do they need within the healthcare system, how are they managing it, what are their fears, what's kind of the uplifts, all of that. And then we're using that to then co-design an intervention, and then we'll be working on doing a clinical trial. So this is kind of, we're wrapping this phase up, and then we're starting this process right now in recruiting stakeholders. So the idea here is we're kind of pulling in this, we're combining this approach of this community-based participatory research approaches so that we can work directly with the communities that will ultimately be served with these groups, but also bringing this human-centered co-design aspects into that so that we not only are just asking people at the end, once we create something, to say, here's a prototype, what do you think? But really embedding them in the design and creation of the process, just suffusing them throughout, which is this generative co-design framework for healthcare innovation, which is a mouthful. And our goal will be to kind of identify, take our intervention we already have, the Web Succeed, identify some cultural enhancements, and then incorporate them and pilot test it. These are some of the quotations from our study that I just wanted to share with you. Secrecy was a huge theme that we heard because of the stigma. So here's a woman saying, promise, don't tell your mom. She's saying that to her cousin. Like, don't tell your mom, those are my mom. They'll find it because they're sisters, right? And so it's like this idea that, I will tell you, I'll tell you my cousin, but aunts cannot know, because then that generation will know and it'll go out of control. Here's a survivor saying, I was terrified. No one's going to come in with a cape and save the day. Like, this is real life. I could really die. Another survivor saying, you feel emptiness and loneliness. And here's a family caregiver who's really talking the loneliness again, that says it's a chain reaction, going home, not having friends, and feeling really lonely. The need for culturally attuned interventions. Here's this woman talking about her mom who has cancer, saying, I remember my mom reading all the diet recommendations, like eat salads and all this stuff, and she's like, I don't even eat half of this thing. This is very American food. This is not what we eat at home. And we heard that theme a lot. Some people said, one person said, I guess this cancer is never out of your mind. I think you never go back to being the carefree person you were. And here's a male caregiver saying, I just went almost silent in terms of not even talking about it because my wife was trying to brave. So then really feeling that they have to hold the grief and the stress for both of them, because he would normally just share it with his wife, but he can't because she's already the survivor at this point. And so that's going to lead us to now the next phases, as I mentioned, of this work. We're kind of getting started on this part and keeping our fingers crossed for an R21 that scored really well. But we'll find out in January. Pray. And so I just wanted to put this up because people are students. People are looking for opportunities for collaboration or to work with us, like I said, we have this co-design process, and we've created a playbook. So once we develop this, really, our goal is to take our intervention and really be able to give it to adapt to any kind of other minoritized group you might be interested in, because we have a process that we've developed and are developing. And so it doesn't matter what the group is, as long as we follow these steps, and then the ultimate product can then be piloted on whatever minoritized group people might be interested in. And we've kept the intervention nimble to allow that, and the process rigorous, and yet with some enough wiggle room so that you can adapt it. We have an ongoing clinical trial of our intervention, and I'm happy to talk more about that later, or you can email me. We have these South Asian data that are ripe for writing up. We have large national data sets of high need, high risk. I was talking to Richard about this earlier, with large national data sets of high need, high risk veterans, because I also work at the VA, and caregivers of high need, high risk veterans. So these are people who are really high risk of dying within the next year. So a really unique data set. So if anybody's interested in working with these, just reach out to me, please. To summarize, family caregivers can play important roles. You're going to hear more about that from others. We need to empower caregivers, but it will require changes at all levels. So we need to understand individual, interpersonal, policy, systemic, institutional levels. And I encourage people to think about dyadic interventions, because when you're not just working with one person, usually you're working with the whole system, at the very least involving people. The closest people who are engaged is important. And that's that. Oh, Susanna Fox, former CTO of the Human Health Service, has this amazing quotation, says, when you ignore caregivers, you leave half the team on the bench. I see one Duke person, that I get the basketball reference, right? So yeah, a lot of people over the years have collaborated, so they're up there, and thank you. Yeah.
Thank you so much. In the interest of time, just why don't we have the caregivers come up first, and then we'll do all the Q&A
Totally
at the same
fine.
time. Okay.
Do you want me to turn this off, or? Yeah.
Why don't I invite my wonderful wife, Christine, and Skip up at the same time, and we'll all four of us sit here and talk.
Oh, you want me to be there too?
Yeah. Okay. Why don't you take the last, or
should I
Sorry,
keep?
yeah.
Maybe we should. Are we passing these along? Then?
Yeah, so if we can.
yeah, why don't we pass
this
the
way.
mic?
Yeah,
Yeah,
okay.
there we go.
Let me get my.
We have two mics. So, oops. So why don't we start with my wife, Christine, and you can talk about your experience when I was diagnosed.
Sure.
And in particular, we can talk about the food comment.
Why don't you keep one, and then we'll pass them
Okay,
the three
I'll
of
keep
us.
this one.
Okay. Yeah, we can pass them on the three of us.
Well, it was a very overwhelming experience, at least at the beginning, because lucky for us, Bryant was diagnosed very quickly within a very short period of time, and he was able to get treated very quickly. However, all those information coming in, I literally felt I could not digest at all. I was bringing a notebook into the clinic when he had his appointment with Dr. Wakely, and they were just talking in medical language that I did not understand. And I was trying to basically take notes, and after a while, I gave up. I basically said, okay, never mind, I don't understand any of this, just tell me what I need to do. But I do think that as a caregiver person, somebody so close to, the patient, you are taking on both the emotional stress and definitely the actual actions of what needs to be done to take the patient for treatment. And you have to very quickly come to speed. Even though you may get a lot of help and whatnot, but you didn't have a moment to really just sort of okay, let me digest what's going on. So luckily, I do feel that we are very, at a position that, cancer, even though it hasn't really happened to us directly, to our family, but it's not a new subject. And certainly lung cancer, I've heard a lot from Bryant. So it's not so novel in that sense. But still, it was a lot. And for me personally, I have to get organized very quickly. But I actually felt overall very hopeful because I felt like, okay, well, in greatest care possible. Um, and so, we just have to do what we are told to do, essentially. But I also embrace it very much as if not a short-term thing, but really think of it as a long-term thing. So, and I actually, after I learned about, I did have to tell my boss that, hey, by the way, I'm going to take time off, here and there, and you're just going to see me disappear. I did share my story with.
She had a business trip actually to Japan, and when I was being diagnosed,
Yeah.
I told her, I said, I think you need to cancel the business trip because I think something is not right here.
Yeah, yeah. And that's when I really realized, okay, he's not joking. This is really serious. And he explicitly said, I want you to be there when they tell me the news. And so, so there's a lot of arrangement that needs to happen. But what I was trying to say is that I learned actually that a few people at work also have experienced cancer. And some people have actually been experiencing it for a long time, that they have immediate families who have been having cancer for like 7 or 8 years. And what I've learned is that there's a lot of emotional ups and downs because, the treatment is working really well, at the beginning, and then you just don't know, and then something is not working right, and then they will have to switch treatment, change something, or maybe, do something a little bit more drastic. So then you kind of go through that emotional roller coaster where you kind of get hopeful, really happy, and then you're like, oh my God, I may have to embrace for the worst or something like that. And so that actually is always very tricky. And also, at the same time, you're trying to manage the emotions with, in our case, also with our kids. And, luckily our kids are generally, very happy-go-lucky kids. So, they take it really well, or they just basically seem, somewhat ignorant of not really realizing the gravity of it all. But I think the key, though, is that definitely lean on your friends and family if they offer. Like, don't turn them down. Don't try to be polite. Like, just take it. And that happens to us, and, people will just, like, show up with food. That was really nice. Like, without me even asking, they said, hey, I know, when are you coming home from your chemo? I'm just going to drop off food around the time that you come home so you have dinner ready to go. Don't even bother with anything. I really, really appreciated that. That was really nice. Or my friend's like, hey, I heard that you're now looking into a more like the cancer-friendly, better diet, switching into vegetarians and stuff. And so my friend's like, just gave me a couple of recipes. I'll cook for you. And I really try to push hard on that with Bryant. And I'm like, okay, you no longer can have any sausages or any red meat or, like, we are going to do vegan now. And he's like, what?
My reaction was like the bubble. I'm like, I don't eat this food. This is not food I eat.
Exactly. And
That's why that resonated with me. I was like, that's not food I eat.
that was definitely a little bit of a battle because, I spent all this time, like cooking like 10 different type of food, like all in my mind, very healthy. And then he was like, oh, there's coconut oil in it. I smelled it. I used to like coconut. No, not anymore. No, can't do it. And so then, it's just the kind of thing. So as a caregiver, you feel a little disappointed. You feel almost insulted. It's like, but you try, right? Like, and you kind of have to have that mentality that like, okay, it's okay. Like, we're just going to get through this. There will be a lot of waste, but just don't worry about it. And I think once you let those go, then you kind of like, okay, it's all right. Like, we just have to go through it one day at a time. And I think that's actually my mantra. I don't plan very far, which is very contrasting from what I used to do. I would literally just like, okay, I know what I need to do for the next few days or maybe a week, but I literally wouldn't think anything else because I just know that I need to be staying as flexible as possible. And you need to be, it's a big ask on a lot of caregivers, and that depends on the personality, because you have to be suddenly be a very patient person. Because, like, especially when you see the patients going through, pain, and or just discomfort, they may not intentionally want to scream at you, but, they could, all right? Like, and you just have to be very understanding, like, it's not on you, that it's really just, it's the situation, and you kind of have to put yourself into their position. But at the same time, you also have to have sympathy for yourself, because you have to remind yourself, and my mom told me this, and it's really funny when I told my parents, oh, Brian has been diagnosed with lung cancer, they said, we want to help you. We want to come to your place right now and help you. But we realize if we come to you, we're imposing on you because now you have 2 more people staying at your house and we're causing more trouble. So we're going to stay remote. We're just going to like be there. And we don't even want to call you because we feel that if we call you, you may be too busy and you just feel obligated to pick up the phone and answer us. So, but we just want to let you know that we're here. Call us anytime. And that was actually really interesting for me because I feel like, okay, now with all the cares that people are offering, I actually have to manage all this, right? So it's sort of, like some people are really organized. They're like, oh, okay, let me get a spreadsheet going and we'll have like different people deliver food for you. But I didn't want to ask for that. but that's actually, there's some people who are in that position and needs to do that. So I would say, get the help, but definitely remember that you have, as caregiver, have to take care of themselves as well. And if basically, if I go down, the rest of the family goes down too. So that's kind of how I look at it. Yeah.
Can you just, before we hand it off to Skip, talk about how complex everything was at the beginning?
Oh yeah, yes.
Just in terms of appointment,
right?
and the medications
Exactly.
and
Yeah,
stuff.
yeah. This is the one part, like, in a way, again, we got really, really lucky because all the appointments was either made for us or Brian knows how to navigate the system, right? Which I think most people wouldn't have the knowledge, like just don't know even where to go about, like who do I call, like that kind of thing, and so and I felt that was actually quite a lot to keep track of. I got myself onto onto the health
My Health,
My Health app, right? And constantly they have all this like appointments,
Usually you have
appointments.
your kids, like you have access to your kids because they're minors or what, and as adults. But I have lots of patients who are on their My Health connected for their parents, right? But obviously I never thought I would need my wife to be on my Health, but I'm like, great, this is great. I can invite you to my Health and you can see all the appointments and everything.
Right. And that's actually, I mean, for cancer in particular, probably, right? It's so many, unbelievable. I think it was even more than when I gave birth. The number of appointments that needs to happen, and I think for I have to be honest that I actually don't like, I just show up. Like I actually don't even know sometimes what those appointments are about, like other than like I read the title with MRI screening. Oh, okay, that kind of makes sense. And then everything else is sort of like, well, what are they talking about? And I think this is where like I think having the caregiving system to help the caregivers understand what's going on, because a lot of times the caregivers become the point of contact for the rest of the family. Because other people, the grandparents or the parents or the sisters, siblings, like lucky we're not in that situation that much, they will call you and say, oh, so how's Bryant doing? I don't know, like he's okay now. So like a lot of that, and they kind of constantly want to be like updated, right? And so, but as a caregiver, you're kind of too busy and you don't necessarily even understand. So I think that is quite a bit, yeah. Mm-hmm.
Great. Well, thank you. We can maybe hand it over to Skip.
Okay.
Great.
Thank you. First, I want to thank Bryant. Bryant's been very helpful with in my
You can
situation.
also clip it to your shirt if
Oh.
that's easier.
Okay.
Then you don't have to hold it. At least. Yeah.
I'll just hold it. It's fine. So my daughter, who's 31 years old, was diagnosed in January with a very rare and aggressive cancer called nut carcinoma. There's really no treatment for it. If you went to a hospital outside of maybe the top 5 or 6 hospitals in the country, it's likely that you wouldn't be correctly diagnosed. So I'm grateful to Bryant and the people here at Stanford. My daughter has had a very, very challenging treatment plan. She had a 14-hour endoscopic surgery, removed a tumor, but also they needed to remove her left eye. She had 6 weeks of daily radiation. She's had multiple rounds and different types of chemotherapy. She was extremely nauseous, required frequent hospitalizations. Her medications are voluminous. We've had at least 100 different doctors and others at Stanford and around the company and around the country meeting with her. And she's currently in a clinical trial now, as there's very, very little expertise around this particular type of cancer. So I have to say that there are times in this discussion of caregiving, it is a business. There are people that are looking at it in statistical terms and lost dollars and what it means. I can honestly say I never thought of myself and still don't think of myself as a caregiver. I'm the father of a daughter who's very sick and requires a lot of care. It's not that hard for me. It's much harder for her. And care really, I thought to myself I would at least share a framework, since you won't be treating statistics, you will be treating individuals. So the care of a 6-year-old is a little different than the care of a 14-year-old, a 30-year-old, 50, 60, 70, 90. The conversations that an 80-year-old doctor can have with a 94-year-old person is pretty different than the kind of conversation you want to have with a 31-year-old person. So I'm a loving father, and there's nothing I'm not going to try to do to help my daughter. It's very difficult for one person to provide all the care that you need. What kind of care does this person really need? And not everybody needs the same care. There are certain things in my family that I can do better than everybody else. There are many things that I can't do. And so the point was made earlier about having a large support group, and I think that's true. And I think if you are a caring person, it becomes just an easier way to think about that. Like, what does this person really need? How will you interact with it? And so for me, what is caring? What does it mean to be a caregiver? What are you actually doing? I think of it in two broad buckets. One is you are reacting to facts and things that happen that you hadn't anticipated. And that just, as a result of not being able to anticipate it, you just have to react to whatever the need happens to be. The care that my daughter needed when a tumor was on her nerve and she was hospitalized and no amount of morphine could alleviate her pain, that's different than the fact that she's out now and out of the hospital, still needs care, but it's very different care. So caregiving is not a uniform thing, and it changes with time. And as you heard before, people call it a marathon. I think it's a sprint and a marathon, and then there are times when there's literally nothing. So it is not one thing, and cancer is not one thing. The other thing that I think caregiving or caring doesn't have to be for a person with cancer. Just being caring in your relationships takes you 80% of the way down to caring for somebody that's sick, and that's anticipating what a person's needs are. I now, and our family knows, what things could change, and then we'll react to the circumstances. But we spend a lot of time planning and anticipating and having contingency plans and so on, and what happens. So, for me, living in the world that I call of Cancer Stan, which is living with cancer, I wouldn't expect, I certainly didn't have any appreciation for what that world is like until you're in it. But, and you heard the point about planning and sort of a change with respect to how you think about the future. But I think of myself more just as a loving, caring parent. And we have, a family that is trying to do everything we can. And we're not always successful at it, but I think if you spend all of your time thinking about the person and what they need, they may communicate exactly what they need, and they may not communicate what they need. Or they may tell you something that you don't think they need. So I think I wouldn't begin to be able to advise anybody else how to care for the people that they love, other than how do you care for them generally and how do you show people that you love them. And then it becomes a little less burdensome and a little less terrible, really. But I guess that's my 2 cents. I'll pass it or.
Why don't
or
we
not.
open it up to questions? I know we only have a couple minutes left, but what we can do is I think we still have the room afterwards.
Yeah, so
Okay.
if folks need to head out for other classes, welcome to, but otherwise we have kind of like an office hours open Q&A.
Yeah. So why don't we open it up to questions and please, yeah, go ahead. Maybe I'll start with a question. Is for Skip. So, as a loving parent and as being a parent, although my kids are younger, our kids are younger, it can be very stressful to be a parent at all ages and in any situations. So how did you
Yes.
manage that aspect of this, for you personally as a father?
It's a good question. And I think it kind of, your relationship with your kids doesn't start at age 30 or 15 or whatever it is. So you bring a relationship already to the table. And what cancer does is for me, it sort of made it more so. So it becomes very exaggerated, and kids were scared and fearful. They didn't know the answer, and I feel fortunate that our kids are older, so they are adults, and we have over our lives together and have worked very hard to have loving adult conversations. I listen to the kids and really listen to them, and I don't discount their feelings, and I don't have the answers, and I let them know that. Some days are easier than others. I think we try to be as gracious and understanding with each other. Sometimes I've had times when my daughter did not want to continue with her treatment where she was in too much pain. I had one daughter who could not focus on her job and needed to take some time off. I could do all the parenting that I wanted to do, and I would parent them differently if they were 8 and needed to go to school. I could force them to do things. But if you're forcing 31-year-old kids to do something, it's not a card that I really want to use very often. So I respect them. We built a relationship over the years, and I think we were fortunate. They gave me the benefit of the doubt when I was not at my best, and I try to give them the benefit of the doubt when they're not at their best. And the one thing that I know is how I told my daughter 3 things. You'll never be alone. You'll have the best care that we can imagine. And however you think you feel today, it's likely that you're going to feel differently tomorrow. So no matter what happened, the Etch-a-Sketch is completely started afresh, and we try to be forgiving and loving and understand that we are in a new country that we don't fully understand or appreciate where it ends up.
Dr. Trivedi, I'm sure you've heard from caregivers like Skip and my wife, and these stories resonate. And what does this look like 5 to 10 years from now? What does caregiving, to use the phrase, look like? You asked us, to help you, but what's your hope for what the system looks like for people with great support systems and for people who may not have anybody? What does that look like in the future?
I want to applaud both of you for all the complexity that you're going through with, as a parent, having your child be sick. I can't imagine as a partner going through that and having your own children and navigating all that. So just incredible amount of strength needed. We seem to be a little bit in this country, a little bit I would love to say inflection, but I don't think it's an inflection quite yet. But we're building momentum to have at least policies to support. And that, we are one of the only, or maybe the only developed country that doesn't actually have a federal policy that supports family caregivers. The closest we have is this FMLA, which is basically 6 weeks of unpaid leave. You can't be fired. And as you can imagine, you just heard, like, since January, since whenever, I don't know the exact diagnosis, my mom, 19 years, right? So how do you fit that in a 6-week unpaid leave period, right? And so there's a lot of momentum now in the current administration, and if you listen to the debates, it actually was brought up a couple of different times. And so my hope is that we actually start having policies that support the needs of caregivers, and that can look a million different ways. There's discussions around having stipends to support financial, because there's a lot of financial toxicity that goes along with caring for, people are paying out a lot of pocket. As well as emotional support and all kinds of different support systems. That's at the policy level. I think where we still need to do a lot of thinking and reimagining is just how we deliver healthcare, period. And suffusing, and I don't know, Bryant, before you had your experience, and we've talked in the past, right? We've had our own conversation over the years, how much caregiving actually was like front and center of the programs you were thinking of and programs you're developing. And it's when we start winding ourselves in these situations is when we start thinking about. So I think the healthcare system needs to be radically changed to really view the social network as not just somebody who is just there, outside and yet kind of allies, but really being integrated into the system. But we can't do it by just adding more and more things to caregivers. And you balked at the term caregiver, and I don't know if you feel the same. When we hear that over and over again, people hate the term caregiver. They really hate it. And I think it's a term that we in the healthcare system it's an identity we've assigned to people. This is my patient, you're the person who's gonna care for him or her, so you're the caregiver, right? So it's a role, but it's sort of given as an identity, and where people are like, I'm the mother, I'm the father, I'm the wife, I'm the child, whatever, my friend. So I think we in the healthcare system just need to really think a lot about how we are approaching this, not just in an incremental way, but in a really transformative way. So my hope is federal policies, a lot of momentum right now in the last, even previous administration, this administration. Hopefully that will continue regardless of what happens in November. That conversation will continue, because I think there has to be a top-down thing. On the clinical side, I think we need to, within the healthcare system, be really innovative in thinking about how we can better engage, better support. Don't tell caregivers you need self-care. That is a BS recommendation. I don't know how you feel. You're like, oh yeah, when, right? Like when you go, what does self-care mean? Like, do I go to a yoga retreat? What are we even talking about here, right? It's these platitudes that, are well-meaning, but they don't actually, there's no teeth to it, right? There's no support there. So I think that, and then, I'm in the research realm, so I think we just need so much more research focus on this. I mean, I mentioned this grant that, well, fingers crossed, what we find out, but it's sort of focused on South Asian caregiving and NIH, and there's never been a grant like that. Like, this is, we're talking the most populous country in the world, and NIH has like never done a project like around breast cancer for South Asia. And it's like, we just need just so much more investment in understanding the humanity behind the conditions and the serious illnesses that we're treating.
Sorry, go ahead.
I was just going to ask.
Before, I think we might have to excuse some folks who need to go to the next
Yeah.
class.
Sure, go ahead. Yeah, if you need to go, yeah.
Let's take a moment, and then we'll resume back to the
Yeah.
Q&A.
Sure,
Sorry
perfect,
about that.
perfect. No
Bye-bye.
worries. Thank you.
Here.
Yeah, please to grab some food,
Thanks.
because we have, I think, a lot of food left. Yes.
Yeah, if you want to stick around for the Q&A, please continue.
I was actually just going to ask a question to the class, because some are undergrads, some are med school students. It's been sort of a broad cross-section not only of cancer, but all sort of topics around the area. And I was curious if there were people here who thought they wanted to become clinically, oncologists or in treatment, or what is it about what Bryant is bringing to the class is sort of stimulating your thinking on it, and so I was just curious to hear from students what's on their mind with this. I assume no one here is currently ill or may have someone in their family who is, but was this sort of a sense of trying to understand cancer from one person's point of view, or people thinking about it as a career, or what? If that's okay, am I allowed
Yeah,
to?
absolutely. Anybody want to
It will require someone to
Go ahead.
answer.
Yeah, go ahead.
And if people want to do some takeout boxes, they're going to take away the students too. So.
Okay. Go ahead.
So I hope that's okay.
Well, I am personally interested in pursuing a career in taking care of cancer patients, but the reason why I took the class is more so to learn about the more like interpersonal level of cancer and honestly about the caregiving as well. I actually had a question about like if you guys, both of you guys, had previous to like finding out these diagnoses, conversations with your family about how you would respond to if something like this happened. Because I feel like this is a question that I ask myself all the time with regard to like how other people, other families handle these things, as well as like how my family would handle such a situation. And I do think there's a role for that preemptive conversation in interpersonal relationships.
Yeah, I think I can answer it in this situation. I mean, basically for us, Brian and I, when we have children, when our kids, the oldest one were just born, we were obviously, planning for Armageddon, basically. What happened if something happened to us? Who is going to take care of our kids, right? And so that actually is the time that when you start talking about all sort of scenarios. What happened if one goes and the other. So like, and usually more tangible things you talk about is sort of the what do you call that? The right where like the child will go to custody. Who's going to be the guardian, right? And so then you started to think about the legal structure, and then you started to think about the financial part of it, which is actually, it ties to, yes, we were thinking about Armageddon and both of us die or something, but it also addresses illness when you cannot, no longer can generate income, right? Because that has a huge impact on the family. And I think that is sort of, a good time that, as a family, as a couple, discuss that. And also, maybe certain, usually certain milestone in your age, as we get older, you start to think about, sometimes it's usually some triggering event, like sort of like, oh, we have an elderly relative, and then you start to think about yourself, and you think about, well, what kind of long-term care would I want? How would what is my wish, in terms of how I want to be taken care of? Should I cannot make the decision? And so I think for us, we always have that conversation. And there's no taboo, because I think part is the fact that, we're both, have this knowledge about, medical care and, whatnot. In some culture, definitely very sensitive. You don't talk about death, but, it's a topic that we feel very comfortable with. So I think this is something that's to be encouraged, actually, by a physician. That will be very nice. Because a lot of times it's like, if if a family member brings that up, then it's sort of like, well, we don't want to talk about that. But then when you kind of put it in the clinical term, what the doctors tell us to think about these things, it's as if like when you encounter your accountant or your lawyer, and your lawyer tell you, you need to write this down, have a trust or something, like you're buying a house now, that sort of thing actually is where like the community in a way can also help. Yeah.
Yeah, I would agree. And obviously, it's a question of when you think they might be ready, but I would elevate it to the level of what kind of, relationship do you want to have with your kids at what time? And I, for one, as they become adults, they need to be treated as adults. And I think all these kinds of conversations are useful, and to do it not in an emergency context, and the conversations will growing, and the conversation you'll have at 14 will be different than at 18, and the job of, I think, being a parent is to know when to change the nature and type of information and the kind of discussion. And so I think this just goes broadly under the category of, consciously deciding how to prepare your kids for whatever you think they need to be prepared for. And that is kind of the first job, I think, that you want to at least consciously be thinking about. So there will come a time when you think it's ready, and maybe they're ready and maybe they're not. But I always think a conscious attention and anticipating things that we know are going to happen. One of the reasons these conversations that we heard last time are so difficult is because, death doesn't exist in the conversations culturally the way it used to. So if you have no experience with death, which was a much more frequent topic of conversations, it's not as hard of a conversation or as foreign. But if you're getting to a point in your life where you have no experience with it, yes, you can expect that it's likely not to be a successful conversation in the way you would hope. So I think there are cultural impediments to a lot of issues around illness and death, which make it harder, which put the onus on the parent. And I don't know of a policy to create a unified guide of good parenting, but I do think that this is just to really amplify the question that I think we both think it's a very good idea to try to prepare your kids for life in all of its ups and downs and realities. So,
Can I add to that? So, I have the experience of, being a family caregiver as well as bringing my scientist and my clinical hats. And I will say that, we're referring to culture, and we're kind of, I think, generally talking of racial, ethnic groups or different minorities group. But there is a culture when it comes to having this conversation that's embedded in our healthcare system too. Our healthcare system is also like clinical providers are not willing to have the tough conversation. So my mom was in the hospital. I mentioned she's in hospice now, but she was in the hospital, and she's, serious illness decline. It's kind of the classic trajectory, decline, plateau. And she was in the hospital in July, and I was there, and I kept pushing for the palliative care team to see her. And I mean, this is a woman who's had really advanced metastatic cancer, there hasn't received any treatment meaningfully since like May or something. And I specifically asked, I said, are we looking at hospice? And even the palliative care team said, oh no, we're not seeing that, right? And basically, a month later, that's what we were having the conversation around. So even the palliative care team, but the oncologists have been very resistant to not just bring up, on their end they don't bring up, but even when I've brought it up and said we need palliative care involved, they've been very reluctant to get palliative care involved to manage pain, even as she was going through chemo. This is last year. And they're like, oh, she's not ready for that. I was like, I'm not saying end of life care. I'm saying palliative care. Like, she's in a lot of pain, and they understand, serious illness pain. So I think that there's that culture which we also fight against, because we need people to be kind but direct, Brené Brown says, clear is kind. You know, we need people to be clear. And Bryant knows the healthcare system, and he can probably read between the lines when they tell things, or at least know what question when people are obfuscating a little bit. But most people will hear what they want to hear. My mom hears what she wants to hear. Like my brother and I get the answers. My parents, you know, and they're very medically savvy, but my mom's like, I just don't, you know, what am I going to do? Knowing this, I don't need to know. So I think that there's also that culture that we need to fight against, that culture of avoiding conversation of death. It's actually suffusing a healthcare system too, because we can always do more and intervene more, and we're interventionists, and we can, you know, we're going to live forever, right? And see the next time the comet comes around. It's just not going to happen, right? So.
I mean, I agree with that. I think there's so many things that are culturally based, especially around specialties. I think oncology has a certain culture. Even palliative care has its own culture. Primary care has its own culture. But you know, really, it's amazing the engagement, because I think any other class, 20 minutes after, everybody gone. So really, thank you, and I don't want to keep you, but I do want to answer Skip's question. How many people are thinking of doing some sort of clinical specialty related to cancer, including primary care? Anybody? Okay. And anybody interested in research in cancer? Okay. Anybody in more of policy side, kind of government? Okay, so that's good. And anybody who has had personal experience either as a family member or personally with cancer themselves? Okay, so a lot of commonalities here. So my suspicion was there probably wasn't just one reason, but yeah.
Can I just ask, for those people who are considering cancer in some form or fashion as a career, was the experience they had personally with cancer, was that a catalyst for wanting to study it further? Did it play a large role or a small role or no role at all? If anyone's comfortable with that.
It's okay, yeah, it's okay. Yeah, sure. I don't want to keep these guys.
If
So,
people,
yeah.
if not, we can move
Anybody
on.
comment about, with his personal experience with cancer, did that?